panel IUSG for giving me the opportunity to talk on this topic of how not to miss TB, and I will say how not to overdiagnose TB as well, right, Soumya and Dr. Vishali. I'll know financial disclosures, and some of the slides, the pictures have been borrowed from Professor Vishali, and you would have heard in different presentation. But I will start the story of a dear friend of mine whom I was treating in Singapore, with history of floaters flashes, progressively worsening, had right eye redness and no pain. Saw a doctor in Chennai for right eye blurring in the vision, was told to make glasses. And this is the findings: cells and 3 plus, 2 plus in the other eye, some vitreous debris in both the eyes. Was diagnosed to have intermediate uveitis, a typical scenario which some of us as uveitis specialists get it. And we are always in dilemma, what do we do with that? And you do a TBT spot, you got a TBT spot positive. The patient wanted further diagnostic confirmation. TB quantiferon was also ordered by one of the treating physician who believe in doing both the tests. Was done. Chest X-ray also showing some densities in the right lower zone requiring further studies. Was likely diagnosis TB-related intermediate uveitis. HRCT was offered. Patient was not keen. Referred to TB unit for anti-TB therapy. Patient declined, and then he said the TB therapy sometimes in different centers in Singapore are given differently. So this is in one of the center where he went. He was asked to come every day to take the medicine under observation, DOTS therapy kind of thing. And which patient being a high flyer, he said, no, I can't, I will probably go to India and all. And then after that, there is a series of things which happened, but eventually the patient was diagnosed as sarcoidosis. And though these were there, and it was a mix of opinions from ophthalmologists, from Singapore and India and all. So this was one of those dilemma which I believe we as uveitis specialists face every day, is whether it is sarcoid or whether it is TB. Now, how does it matter to us whether it is a sarcoid or TB? Because probably you are going to start on a treatment if you're diagnosed to him to having a TB related uveitis on antitubercular therapy, which is a commitment for 6 to 9 months at least, if not more, and you're going to put him on that. And that's where the borderline is there. So therefore, while we are going to talk on this topic of how not to miss TB, I'm also going to cover some of the aspects which will also highlight about what are the things which can probably help you differentiate from the TB versus sarcoidosis. Again, beautiful slides from Dr. Vishali again for this thing. So some of the hallmark features of granulomatous uveitis, particularly in the context of both TB as well as sarcoidosis: mutton fat granulomatous creatic precipitates, Bouchard's nodule, granulomas in the angle, Kepi's nodule, which are there and which can be suggestive of either TB or sarcoidosis. Also, there can be nodules in the angle with trabecular meshwork with tendency to form tent sepate peripheral anterior syne K, suggestive of sarcoid, though it's been reported in some of the literature. How much, we don't know. One of the paper which we did in Moorfields also we saw this finding there. And also sarcoid can be there in vascularized granuloma if it is seen there. Intermediate uveitis, I always call it as a flip of coin. Whether coin comes up heads, probably TB, and comes up tail is sarcoid kind of thing. But jokes apart, it is again one of the very challenging thing when you get certain features of intermediate uveitis. Within that or along with that, there can be certain lesion which can be, and we are just talking about the clinical examination. I have not touched base upon any of the lab tests, because the clinical examination is the first thing which is going to help you to go and arrive at a particular diagnosis. The next can be the chorioretinal peripheral lesions. In sarcoidosis, these are very small in size, white or whitish yellow, and present in clusters. Whereas in TB, these are larger in size, not in clusters, and present in next to the vessels, in the vicinity of the vessels. So this can be something which can be differentiating there. Sarcoid choroidal tubercles, small, are most common intraocular presentation in TB uveitis, seen mostly in the patients with pulmonary TB. So this has been reported in a couple of papers where they have reported about this small nodules, whether which can be unilateral or bilateral, fewer in numbers, but can be quite a lot of number as well, grayish white to yellow with indistinct borders, and mostly in the posterior pole. However, solitary granuloma with serous, overlying serous retinal detachment can be suggestive of TB related uveitis which can be present in that particular patient with the posterior uveitis. Optic disc can be involved either in sarcoid or in patients with TB, but according to the literature, again not much of literature is present, has been commonly reported in patients, more commonly reported in patients with sarcoid as compared to TB. But having said that, presence of optic nerve does not rule out TB-related optic neuritis or TB-related posterior uveitis. Retinal vasculitis is again one of the very challenging thing to diagnose, whether it is a TB-related or non-TB related. Again, this is a patient with 34-year-old Mandu negative hilar lymphadenopathy, only one of the eye involved, with bilateral, more common sarcoid and probably unilaterality, and that too in our observations in Moorfields in one of the data which we did, we saw more commonly left eye involved. Now, Mark Westcott and I, we've been debating about why left eye can be involved, and some of the things can be whether the heart circulation and all some of the theories which we are trying to put together, but we really do not know. It is at a very hypothesis. But one thing which has really helped us to understand TB-related retinal vasculitis is occlusive nature. So you can see really the occlusive nature which suggests towards TB-related peripheral retinal vasculitis. Now this is a beautiful paper from Anirudh Agrawal and the team from PGI when he was in PGI, and including our dear friend Francesco Picci sitting here, and looking into some of the lesions and describing whether this can be TB or non-TB or sarcoid. So I don't know. Francesco, which are the TB one, the top panel or the bottom panel one? Top is the TB one, correct, good. So the top larger lesions, yellowish lesions, you look like an abscess kind of thing, those are suggestive of TB. So this is where I feel AI, which we have just given the talk in the previous session, can be quite helpful. If you really see the application of AI, I will not call diabetic retinopathy, but this is where AI can probably help you differentiate one from other. The bottom panel is about the sarcoid, where there is a more flatter lesions, not so creamy yellow kind of a thing there, and this is where, and we got a confirmation from expert. So if anything goes wrong, you can reach out to Francesco. Again, presence of subretinal fluid, larger granuloma, suggestive, the larger the bottom panel, suggestive of TB, where it you see a very solitary large granuloma, subretinal fluid, suggestive of sarcoid kind of a thing there. Smaller granuloma, multiple granulomas, flattish, the choroid does not get elevated so much, suggestive of sarcoid rather than TB. So I think this is something very helpful, and one place where OCT can be really useful in picking up some of these choroidal granulomas if there is a choroiditis which is giving you some bit of a trouble. Again, some of the lesions which are suggestive of TB-like, you can see a very abnormal looking or a yellow looking lesion, and which is increasing in size, suggestive of TB. Now this is about some of the clinical presentation. I just wanted to put in a bit of a research angle to it, and historically these two entities have been correlated quite well, and Soumya's work will really tell us how much is the immune thing which is suggestive of sarcoid, or the infective component or the immune component driving the TB kind of thing is there, and this can be quite helpful. So one of the paper which we published many years before was about the concept of, are we talking about these two entities being the spectrum of these two things? And the reason of putting it in front of the general audience is just for us to give us an understanding about what makes us think about the treatment. So this is again a hypothetical concept where you think it is a really sarcoid. I call it as a SS taken from leprosy classification. You give immunosuppressive therapy. Where you think it is sarcoid tuberculoma, immunosuppressive, and where it is TB kind of thing, it is anti-tubercular therapy. Where you think TB, you only give TB therapy, no immunosuppression. So this is the idea of if you want to bracket and segregate your classification. But again, a concept note, haven't been proven, but something which you can take. So to conclude, there is little evidence, at least based on the literature, about differentiating between these two. But some of the pictures which I have shown, and probably you must be building up some of the pictures also. So if you put together some of the pictures which will probably allow us to help us differentiate TB from other non-TB entity based on the pattern recognition, and future research can probably help us do a bit more into this thing. So with that, I would like to thank once again IUSG for giving me the opportunity to present on this TB science and all. Thank you.
Thank you, Rupesh. I think one very important message that Rupesh gave, that please do not test every patient of uveitis for TB test, and if TB tests come positive, start treatment. For example, if it looks like HLA-B27 associated uveitis, please do not order a Monteus, Because if Montius comes positive, then you will be highly confused whether to treat or not. So the phenotype is very important. If it is looking like TB, only test for TB. Don't test TB for every uveitis patients. Any questions for Rupesh? Peter, any comment?
Yeah, I think I'd absolutely agree with that. The only thing I'd add is that the COTS study and the SUN criteria help you to know which of the phenotypes clinically that present where TB is a likely diagnosis and where sarcoidosis is a more likely diagnosis. So I think they're quite useful